let's jump right into this explainer. Look, if you've ever stared at a urology operative note and just felt completely overwhelmed by the sheer volume of procedures bundled into a single session, trust me, you are not alone. Urology coding is notoriously tricky, but today we're going to demystify the whole shebang. Acting as your senior coding auditor and compliance educator, I want to give you a crystal clear, rule-based framework. We call it the Anatomy to Action Framework, and it's designed to literally map clinical anatomy straight to your coding actions, which is going to drastically reduce those frustrating claim denials. So here's our roadmap for today. We'll start with the foundations of urology anatomy, then move into cystoscopy and the big diagnostic versus therapeutic debate. After that, we'll hit coding biopsies and stents, then lithotripsy coding by approach, and finally, we'll wrap up with the prostate clinical coding pathways. Let's get right into it. Section 1. The Foundations of Urology Anatomy. You see, before we can even think about assigning a single CPT code, we have to establish exactly where we are in the body. I mean, anatomy dictates absolutely everything here. The urinary tract is strictly zoned. For example, massive procedures like a PCNL or an ESWL, those happen way up high, in the kidneys and the upper ureters. Meanwhile, cystoscopies happen much lower down, in the urethra and the bladder. If the operative note you're looking at doesn't pinpoint this exact location, honestly, your claim is dead on arrival. We also really need to map out the prostate gland. It sits just below the bladder, completely wrapping around the prostatic urethra. And that location is clinically huge because any enlargement of this gland, like you'd see with benign prostatic hyperplasia, or BPH, is going to directly cause urinary obstruction. Now, as we'll see in our final module, this exact same gland can trigger 3 totally different clinical and coding stories.
Moving right along to Section 2, Cystoscopy, Diagnostic versus Therapeutic.
When we're looking at cystoscopies, we absolutely must distinguish between a simple look around and a true surgical intervention. And the equipment actually gives you a massive clue to the coding pathway. If the provider uses a flexible scope with just some local anesthetic jelly, they're typically just taking a diagnostic look, maybe checking for the source of hematuria or recurrent UTIs. But if they're using a rigid scope under regional or general anesthesia, that means they are passing surgical instruments to actually do a therapeutic procedure.
And that brings us to your golden compliance rule. CPT 52000 is your base code for a diagnostic cystoscopy. Now listen closely, if a therapeutic intervention, like a biopsy, a tumor fulguration, or placing a stent, happens during that exact same session, you never ever bill 52000 separately. That diagnostic look is completely bundled into the therapeutic work. If you unbundle this, you are practically begging for an audit, and nobody wants to face the wrath of an auditor.
Let's dive into Section 3, Coding Biopsies and Stents.
So when you're dealing with bladder tumors, the size of the lesion is what drives your code, family. It's pretty straightforward. A small lesion, meaning half a centimeter or less, is coded as 52234. A medium one, up to 2.0 centimeters, is 52235. And a large lesion, anything over 2.0 centimeters, gets the 52240. This means strict, precise documentation of dimensions is an absolute requirement for a clean claim. If your surgeon just jots down tumor fulgurated without giving you a size, you literally cannot code it accurately.
Location is also everything when dealing with biopsies and fulgurations. If the doctor biopsies a lesion and then fulgurates that exact same lesion, you only code the fulguration. The biopsy is bundled right in. But if they biopsy one lesion and then fulgurate a totally different one, you get to code both. Usually you'll just append a modifier 59 to the biopsy code to show it's distinct. Oh, and a quick tip, if they are just fulgurating a biopsy site simply to stop the bleeding, that is never separately billable.
Let's put this logic to the test with a quick knowledge check based on a scenario you might see in the clinic tomorrow. Your surgeon performs a rigid cystoscopy and fulgurates a 1.2 centimeter bladder tumor. No separate biopsy is taken. Take a second. How are you going to code this?
Well, since the lesion is exactly 1.2 centimeters, it lands squarely in that medium tier. That means CPT 52235 is our winner. And remember, if you tried to code a 52,000 for the cystoscopy on top of this, you'd be breaking that golden compliance rule we just talked about.
Now, when we talk about stents, let me show you what a perfectly compliant operative note actually looks like. It explicitly states the stent size, in this case 6 French. It gives the length, 26 centimeters. It names the type, and crucially, it specifically mentions that fluoroscopic guidance was used to confirm the proximal curl is up in the renal pelvis and the distal curl is safely in the bladder. Getting this level of detail is a total game changer. It makes your coding practically bulletproof.
All right, let's look at Section 4, Lithotripsy, coding by approach. For lithotripsy, the surgical approach dictates everything. Just think about the massive difference between an ESWL and a PCNL. With ESWL, you're using non-invasive external shock waves to blast small stones from outside the body. But with a PCNL, the surgeon is creating a direct, percutaneous tract right through the skin and straight into the kidney. They usually do this to clear out those massive, complex staghorn stones. These are two completely different clinical efforts.
Because of this huge difference, your operative note has got to explicitly state the approach. Choosing between external waves, threading a laser endoscope up the ureter, or punching a percutaneous tract changes the entire CPT code family. You're looking at 5590 for the external waves, 52356 for the endoscopic laser, and the 50080 family for percutaneous access.
So before you finalize any lithotripsy coding, you absolutely must run through this definitive 5-question checklist to avoid those revenue-killing denials. 1. Where exactly was the stone? 2. What approach was used? 3. Did we just break the stone or did we actually pull the pieces out? 4. Was a ureteral stent left behind? And 5. Does the op note actually support all of this?
Here's another quick knowledge check, and this highlights a massive pitfall coders face every single day. You're reading through an op note, and it says, stone fragmented with holmium laser. Awesome. But then, the note just ends. It never mentions if those fragments were actually retrieved with a stone basket. What do you do?
The only right answer here is to query the physician. You cannot just assume extraction happened just because they broke the stone. If you add an extraction code without explicit documentation of retrieval, you're looking at a severe compliance risk. The rule of thumb, if it's not documented, it simply didn't happen.
Okay, let's head into our final module, Section 5, Prostate Clinical Coding Pathways.
Take a good look at the prostate's anatomical neighbors here, especially the seminal vesicles and the rectum. Knowing these adjacencies is critical because they dictate the surgical approach. For instance, knowing the rectum sits directly behind the prostate perfectly explains exactly why a transrectal ultrasound biopsy is performed the way it is. It's all about anatomical access.
Now, this exact same gland yields totally different coding pathways based on the clinical indication. Let's do a direct head-to-head comparison between simple and radical prostatectomies. If the indication is BPH causing severe obstruction, say a massive 150-gram adenoma, you're looking at an open, laparoscopic, or robotic simple prostatectomy. The core surgical principle here is enucleation. They are only removing the inner obstructing adenomatous tissue while strictly preserving the true prostatic capsule. But what if the indication is localized prostate cancer? Now we shift to a robot-assisted radical prostatectomy. The core principle completely flips. We are talking complete surgical excision of the entire prostate gland, along with its capsule and seminal vesicles, usually combined with a bilateral pelvic lymph node dissection and a vesiculo-urethral anastomosis. So the coding focus changes drastically. BPH means coding for the diagnosis, the approach, and adenomatous removal. Cancer means coding for the cancer pathology, the approach, and the lymphadenectomy. You have to capture those 4 driving documentation elements: the cancer diagnosis, complete gland removal, the specific surgical approach, and the lymph node dissection status. Accurate coding all comes down to precision. Does your clinic's documentation consistently connect the anatomy to the correct action? To ensure your claims survive a pre-billing compliance audit, you must cross-reference your essential audit references: the AMA CPT Professional Guidelines, ICD-10-CM coding conventions, NCCI Policy Manual bundling edits, and Payer Local Coverage Determinations, or LCDs. Let's wrap this all up with our master wrap-up, the 5 golden rules of urology coding. Rule 1. Diagnostic is always bundled into therapeutic. CPT 52000 is never billed separately with a therapeutic cystoscopy. Rule 2. Lesion size and anatomical site drive your code family for bladder and urethral tumors. Rule 3. Surgical approach dictates your lithotripsy family, like ESWL versus laser URS versus PCNL. Rule 4. Clinical indication routes your prostate pathway. An elevated PSA leads to a biopsy. BPH leads to an endoscopic or simple procedure, and cancer leads to a radical prostatectomy. And finally, Rule 5. Documentation precision. Capturing laterality dimensions, basket extraction, and stent context is exactly what separates clean claims from costly denials. Are your clinic's notes precise enough to pass the test? Like, share, subscribe to Decode Healthcare with Harshal.